colleagues. My name is Dr. Alan. I am going to be moderating today's session. I hope we all had a productive day. So without wasting much of your time, allow me to introduce our speaker today. I hope you can all hear me. If someone can confirm.
Yes, we can hear you, Doc.
Okay, thank you. Thank you for that. So allow me to introduce our speaker for today. Our speaker for today is a trailblazer in her own right. We all know her. She graduated with a Bachelor of Dental Surgery degree from the University of Zimbabwe, and then recently graduated with a Master of Dental Surgery degree in the specialty of oral and maxillofacial surgery. And this was from the University of Nairobi. So as of now, she is stationed as a senior registrar in the Department of Oral and Maxillofacial Surgery at Central Hospitals in Harare, and she's also with the University of Zimbabwe. She is a member of Proud Association ZiDA, a member of AOCMF. I will not try to twist my tongue to pronounce this, and a member of the International Association of Oral and Maxillofacial Surgeons. Ladies and gentlemen, please help me to welcome Dr. Muungani. I will hand over to her.
Thank you, Dr. Gura, for the introduction. Also, can you confirm if you can hear me?
Yes, Dr. Loud and clear.
Okay, thank you. Let me just start sharing my screen. Okay, can you see my screen?
Yes, I can see your screen.
Okay, it's fine. Okay, so thank you everyone for this platform that you've given me to give this lecture. So today we're going to be discussing life-threatening cervicofacial infections. Okay, so these are cervicofacial infections in terms of the region, that is the face and the neck. That's the facial with just a C without an S. And then they're cervicofacial in the sense that these infections, they spread along the facial planes of the head and neck region. So we just want to take a brief look at the literature review on cervicofacial infections. We want to be able to appreciate the anatomy which is relevant to these infections, and then discuss the commonly encountered life-threatening cervicofacial infections. We also highlight potentially fatal complications of the same. And then there is an African study which was done, which we also just briefly take a look at, and we went up the discussion with taking a look at potentially high yield action points which we can implement in order for us to minimize or reduce the risk of mortality from these infections. So life-threatening cervicofacial infections are polymicrobial infections which spread along the facial planes of the head and neck region. And in some texts, these are also referred to as deep cervicofacial infections, and they mostly manifest as abscesses or cellulitis. And the notorious ones which we're going to take a look at in this discussion are ludus angina and cervicofacial necrotizing infections. But we do have a number of facial space infections that we commonly deal with on a day-to-day basis, and that includes the submandibular abscesses. We have the muscular space abscesses. We also even have the buccal space abscesses. Okay, and then when we have lymphatic and hematogenous spread of the same, then we end up with regional and systemic involvement, and this involvement also present with its own signs and symptoms, which the clinician should be able to pick up. In this slide, we see two patients. The one to your left, that's a patient with ludus angina. So what's key for us to note here is that for ludus angina, we're going to be having a bilateral swelling. And in this patient specifically, you can see also in the region towards the neck, this impending necrotizing fasciitis is evidenced by the discoloration of the skin. And to the patient in picture B here, we can see This patient actually had necrotizing fasciitis of odonogenic origin, and in this case, it was now extending from the upper neck to the junction of the abdomen and the chest. So this is how extensive it can be. And in some instances, it can even go down even to the lower limbs, and that's just coming from a tooth infection. So that can also happen. So we need to be prepared for those situations. So during the pre-antibiotic era, the mortality risk from these infections in most cases would go above 50%. But in the past few decades, the mortality has declined to around 2 to 10% due to improved healthcare, notably antibiotic discovery. So these infections, nevertheless, they do contribute a significant workload in the field of oral and maxillofacial surgery. And then also, they also contribute quite a number of deaths, which could possibly be avoided. So what's the etiology of these infections? So these infections are mostly odontogenic in origin. When we have our patients with dental caries, that's the majority of the patients. In most cases, over 70% of patients with these infections will have an offending tooth in their mouth. But then we can also get situations where we have contiguous spread from pre-existing pharyngotonsillar infections, especially in the pediatric population. You can also get super infection of pre-existing cysts and tumors. And then also you can even get also some cases where you can't identify the source of infection. So those are going to be the elusive etiologies, and it's usually common also in the pediatric populations where you get a child coming with submandibular abscess and you can't tell the source of that infection. So it can also be elusive. So we have a number of risk factors for the development of these infections. We can divide them into local risk factors and systemic risk factors. And for the local risk factors, we can also give them like 2 arms. The first arm will be like infections or infectious conditions like the dental caries, periodontitis, sialadenitis, and tonsillitis. Then we have conditions which predispose to the development of infection. Those are going to be your cysts and tumors, and also even jaw fractures. And then for jaw fractures also, we can even have direct inoculation of the pathogens. So those will be the risk factors under the local arm. And then for systemic risk factors, immunosuppression is going to be the main risk factor, where we have patients, for example, with uncontrolled diabetes mellitus, patients with uncontrolled HIV infection, and in some instances can be medication-induced. For example, patients who are prolonged steroid use, and then patients who are on immunosuppressants for organ transplants, and then also in patients on chemotherapy. So those are at risk of developing these infections. Then also malnutrition on its own is also a noted risk factor for the development of these life-threatening infections. We just want to take a look a bit at the anatomy. So here, the picture to your left, okay, we can see the skin, we can see the superficial adipose tissue, and under it we have the superficial fascia. Okay, under the superficial, or rather inferior, or the deep fascia. So the deep fascia in most parts of the body is going to have multiple layers. And if you take look at the picture to your right here, just a depiction of the fascial planes within the neck envelopes muscles. That's going to be the investing deep fascia. And then here we have the pretracheal, which is extending inferiorly from the oral region. So this pretracheal fascia just anterior to the trachea. This very important fascial plane for the transmission of the spread of infection from the oral region into the mediastinum. We also have the prevertebral fascia, also just anterior to the vertebral column. So these fascial planes, or this fascia, the fascial layers which we spoke about, they give us what we call fascial spaces, are actually potential spaces. They don't really exist in good health, but they only show up, or only come to acknowledge them when we have fluid accumulation within the confines of the facial layers. Okay, so these facial planes, these facial spaces can be divided into 2, with the primary facial spaces and the secondary facial spaces. The primary facial spaces are the reflects the root space into which dental periapical infection spreads by virtue of them having a dental root or the apex of the root within that space. And so an example would be region, the canine and the back regions. Those are going to be the primary spaces in the maxillomandibular region with the submental, the submandibular, sublingual, and also in the back wall. So these are the primary facial spaces, the first place where you get dental infection spreading into. And then from there, we have the secondary spaces. So the secondary spaces are the spaces whereby you're going to get the infection by means of spread from the primary space. Examples are going to be the mesenteric, pterygomandibular, the temporal spaces. They comprise what's known as the masticator space, the one which, when it's involved, the patient is going to present with trismus. Then also you have the next spaces, that's the lateral pharyngeal, the retropharyngeal, you have the prevertebral and the vertebral space. These are the facial space that we have, even if some more spaces, but these are the main ones. And this picture is just depicting the different areas just beneath the tongue, okay? And then beneath the mylohyoid muscle, we have the submandibular space, and then between the anterior bellies of the digastric muscles, we have the submental space. These three spaces, the sublingual, submandibular, and submental space, are going to be involved bilaterally in ludus angina. Okay, so we talk about ludus angina. So ludus angina was described in 1836 by Wilhelm Friedrich von Ludwig, and like was already defined before, it is the bilateral, sublingual, submental, and submandibular space infective cellulitis. So when you take a look at some of our records, or maybe when we hear people examining a patient, most patients with just submandibular abscess are going to be erroneously categorized as having ludus angina. But remember, this is the bilateral. So those are the three perimandibular spaces which are involved in ludus angina. Okay, and why those spaces? So you realize that the second and third molars of the mandibular, so the second and third mandibular molars, the roots, they tend to extend beyond the level of the mylohyoid muscle. And so when we have infection, periapical infection of this teeth, that's already like seated underneath the mylohyoid muscle, which is already the submandibular space. So the second and third mandibular molars are mostly implicated, and the pathogens which are commonly isolated include the Staphylococcus species, the Streptococcus, the Peptostreptococcus, Fusobacterium bacteroides, and for the actinomyces, usually in war zones where we have contamination from the environment, you can get actinomyces. So the Staphylococcus aureus and Streptococcus pyogenes are some of the commonest pathogens which are going to isolate in these patients.
Dr. Muungani, if I may interject just a moment. I got a request that a few people are getting left behind. If we just slow it down a little bit.
Okay, thank you. I will try and speak slowly. Thank you.
Thank you, Doctor.
Okay. All right, so how does ludus angina present? So ludus angina is going to present with a bilateral Browning heart induration. And we're going to have cervicofascial pain because of the involvement of the neck. So when you have that pain, most patients are going to present with a limited neck movement. And when you check the history, you realize that most of them are going to have a positive history of toothache. And as you can see in the picture to your right, because of the infection, the fluids piling up beneath the tongue, you're going to have an elevated or protruded tongue. And some patients are also going to present with dysphagia, sometimes to a point whereby they struggle with swallowing fluids. So most patients are actually going to present with dehydration, which we'll need to take care of when we attend to them. And then the patient also may present with dysphonia, that's an altered voice, and then also trismus when the masticator space is being involved. So what are the complications that can arise from ludus angina? So the two main complications that we'll need to take a look at in this discussion. Okay, so the first one is actually upper airway obstruction. So the upper airway obstruction is going to arise from the airway edema, the tissues which surround the airway. When the edematous, that's going to narrow the airway. Then also we can have pus collection within those facial spaces. Then also even the elevation of the tongue in a superior posterior direction, that's going to cause obliteration and narrowing of the airway. But we're going to discuss this a bit more in the upcoming slides. Then when also get necrotizing fasciitis as a complication of low-dose angina, then sepsis and septic shock, that's going to be the second other complication which we're going to discuss further. Then cavernous sinus thrombosis. For cavernous sinus thrombosis, there's what's called the danger space of the face. This is a place or a region where we have communication between the extracranial and the intracranial venous systems. An example would be the communication between the facial veins and the superior ophthalmic veins. You know, the superior ophthalmic veins are going to drain into the carotid, so the cavernous sinus. So that area where there's communication, so you just have your low-dose angina, but now you're ending up with intracranial complications. Okay, one very rare complication which I actually came across was loss of sight. So this is a patient that we attended to at Kenyatta National Hospital in Kenya. This patient presented with low-dose angina. And during the process of his illness, or during the period of his illness, apparently he lost sight in his left eye, where to a point whereby there was no pupillary reaction to light. He couldn't pick up any light at all. But fortunately for him, after around 6 weeks post the loss of sight, he started regaining the sight, but he never really fully gained the sight. The last time that I followed up on him, he could only pick up hand movements. So you can get loss of sight from low-dose angina. That's a possibility. Okay, some other complications which can get, can have descending mediastinitis because of those facial planes which arise from the, or which extend from the oral regions to the sternum. So you can get descending mediastinitis. And then also you can get empyema-thoracic. So now that's going to be a purulent pleural effusion in a way. Rather, we have an effusion within the pleural space, which is thick, like in this patient. So this patient, we managed him at Harare Hospital. He was, I think, around 26 years old. And you can see the obliteration of the lower lobe of the left lung. This was empyema-thoracic. So in this case, in these patients now, these ones are going to require a chest drain so that at least the lung can fully expand. So this is one complication. And in terms of the patient's presentation, sometimes when you talk to them, they can actually tell you that they're having pleurisy, chest pain. So when you talk to them, someone is telling you about pleurisy, then just keep this in mind. They could be having empyema-thoracic. You can also get erosion of the great vessels, because remember also that deep fascia, there's a point which encircles the carotid vessels, what we call the carotid sheath. So when we have involvement of infection within the carotid sheath, you can even get erosion of the great vessels, and this can result in fatal hemorrhage. And then ultimately you can have loss of life. So we just want to take a look at the compromised airway. What are the clinical signs that one should be able to pick up when you're examining a patient with low-dose angina? So for the compromised airway, this was called the double tongue sign. If you take a look at this picture to your right, we have inflammation and elevation of the floor of the tongue. So the floor of the mouth. So the floor of the mouth is shown here by the white arrow. So this floor of the mouth is raised to a point whereby the tongue also is raised, now indicated or shown by the red arrow. So this is the double tongue sign. Some will refer to it as the hot potato appearance. But this is all coming up because of the edema and the accumulation of pus in the sublingual space. Then you can also get altered voice, dyspnea, limited leg movement, and what we call the lean over position. So sometimes for the patient to be able to improve on their breathing, they'll tend to lean over. I'll give an example of like putting your elbows on your knees, like you're leaning over, just to try and improve the air entry into the lungs. Then you can also get patients presenting with saliva drooling. And when you get to stridor and cyanosis, this will be extreme airway compromise, requiring immediate intubation or tracheostomy. So how do we assess ventilation? So very simple things which we can do. I assume that most of us will pass through an internal medicine rotation during our training. So chest examination is going to be very key in terms of managing these patients. I know some of us will say maybe we're dentists, but that's the reason why we did some of these rotations, so that at least when you get patients like this, we're able to at least do an accurate assessment, which will help in their management. So we're going to talk a little bit more on chest examination in the next slide. And then also pulse oximetry, you want to check the oxygen saturation of the patient's blood, because when we have compromised ventilation, then they might desaturate. We're going to have low saturation level. So remember, in a normal healthy adult, we're talking about at least 94% to 100. But in patients who are elderly, you can even go down to 91%. It might still be considered as normal. Okay. And then also a chest radiography we don't do chest radiography for everyone, but those patients where you have a high index of suspicion that they could be having chest involvement, those are the ones that you might want to do a chest radiograph on. So what are the simple things that we do on a chest examination? You want to check the patient's respiratory rate. And for adults, we're taking a look at 12 to 16 breaths per minute. You don't want the respiratory rate to go below 10 breaths per minute. You also don't want it to go above 29. So respiratory rate, just that simple vital sign, is going to show us that maybe we're going into a dangerous zone for the patient's health. They want to take a look at chest rise. The chest rise should be equal and bilateral, so equal bilaterally, and then also check if the patient is using any accessory muscles of respiration, or if there's any nasal flaring, because it's going to show us that the patient is having respiratory distress. We also want to percuss the patient's chest, and dullness might indicate that we have a pleural effusion, which might need further investigations. And then you do auscultation to check for the ANV, and also you might even get to hear some crepitation. So chest examination is very key for patients with low-dose angina, because you want to be able to try and identify any possibly fatal complications before they occur, so that you can intervene on time. So that's the chest examination. So we just want to take a look at sepsis. So sepsis is defined as bacterial infection of the blood with resultant aggressive dose response and organ dysfunction. So what's happening in sepsis is that you're going to have negative effects from the endo and exotoxins from the bacteria, and then also the inflammatory markers from the patient's own immune system. So these are going to combine efforts, and we end up with organ dysfunction. So there are some very quick assessments that we can do on our patients. There's this QSOFA. So QSOFA, it stands for Quick Sequential Organ Failure Assessment. So it comprises of 3 elements which you need to take a look at. Does your patient have altered mental status? So when you have a patient with altered mental status and they've got low-dose angina or maybe necrotizing fasciitis, already you're thinking sepsis. Okay, and then the other thing is the blood pressure of the patient. So when you have a patient with a systolic blood pressure, which is less than 100 millimeters of mercury, that's also a red flag. And the third one will be the respiratory rate. So just those three points. When you have more than 2 of them, or when you have 2 or more, you're thinking of sepsis. So we need to be able to pick them up when we examine our patients. In this slide, is just showing us the different organ systems which can be affected by sepsis, where we have the altered consciousness, the tachypnea with jaundice, hypertension with oliguria or anuria. So even just asking your patient, most of our patients sometimes will not be catheterized, but you're able at least to ask them how many times they are going to the bathroom. That will also just tell you generally. But then also when there's a proper chatting, especially maybe for ICU patients, you're going to be able to pick up the input and the output to the patient. And then also when you do your blood works, the platelets, when we have thrombocytopenia, you're thinking of sepsis as well. So sepsis now can gravitate towards septic shock. So septic shock, that's hypotension, which is due to uncompensated vasodilation, secondary to bacterial toxins and inflammatory markers. So the inflammatory markers and the bacterial toxins, they're going to result in vasodilation. When you have vasodilation, it means that you're going to have a low blood pressure because of the low resistance within the vessels. So some other definitions of the same, we have this surviving sepsis guidelines. I would encourage us to read these guidelines, especially for those who are working like in a hospital setup. You might need to just take a look at these guidelines. So they define septic shock as persistent hypotension, which requires vasopressors to maintain a mean arterial pressure of more than or equal to 65 millimeters of mercury. Okay. And then another definition of the same would be blood lactate levels more than 2, despite adequate volume resuscitation. But when you take a look at these two definitions from the surviving sepsis guidelines, you already see the importance of us having equipment to be able to monitor the patient's blood pressure, the laboratory equipment for us to be able to check the blood lactate. So these are also going to be very key in terms of monitoring and management of the patient with life-threatening cervicofascial infections. So let's just remember also that septic shock and sepsis, that's a medical emergency. So we need to be able to pick up the signs and be able to communicate, work as a team so that we can try and save lives. So the clinical signs of septic shock, what you're going to see, the patient might present with tachycardia, hyperventilation, cold clammy extremities, prolonged capillary refill, like when you press on the nail bed and you release, it's supposed to become pink within 2 seconds. So if it takes longer before it turns pink again after the blanching, that means we have delayed capillary refill. That's also a sign, possible sign for septic shock. The patient might present with fever or hypothermia. They might also present with profuse sweating. And when you get to restlessness and confusion, this is the danger zone. So we need also to be on the lookout for that. So how do we assess patient for septic shock? The vital signs, and what we're going to take a look at also, specifically under the vital signs, we want to take a look at the blood pressure measurements. So you have to do serial blood pressure measurements for the patients, and you can have low blood pressures where the systolic blood pressure is less than 90 millimeters of mercury. And then also for those who work in the hospitals, if you've seen, sometimes you can get a patient's chart and it's written under blood pressure, unrecordable. I've had one patient that I had to manage a point back where we try to get the patient's blood pressure and we're unable to record. So that's a very, very dangerous sign when you can't record a patient's blood pressure and you're positive that the equipment that you're using is actually functional. So a low or unrecordable blood pressure, that's a grave sign. And then you also want to check the oxygen saturation when it's low or unrecordable, because remember, with the septic shock, you're having a compromised tissue perfusion. So because of that, when you try to get the SpO2 for the patient, sometimes the reading is very low. Maybe now we're getting the 80s, 60s, thereabout, or sometimes it's not even reportable. So those are some of the true vital signs to be able to look out for. And when you took a look at the investigations, blood gas analysis, we've already spoken about the high serum lactate. When it's above 4, that means really the patient's condition or the circulation, the tissue perfusion is severely compromised. And then also metabolic acidosis, you don't want this happening. Okay, and then another investigation which can do is blood culture. And usually we prefer doing blood cultures before antibiotic administration, but sometimes we might not be able to do that. But where possible, we need to do the blood cultures. And then also, like we've already highlighted before, we want to check also the urine output of the patient. And remember that the normal urine output, that's going to be 0.5 to 1.5 mL per kg per hour. So we need to keep that in mind. So this slide just summarizes the investigations which we need to do for our patients with these infections. We speak about the full blood count, the urine electrolytes, and then for the liver function test, one aspect which is of importance would be the albumin levels, because remember that albumin is a negative acute phase reactant. It means that when we have sepsis, the levels of albumin in the patient's blood, they go low. So remember, they're supposed to be at least 35 grams per liter. So when they go low, that already means that the severity of the sepsis is at a higher level. Okay, you also want to check out for any pre-existing risk factors, sometimes which might actually be undiagnosed. We spoke about the diabetes mellitus. You might want to do the RBS, but glycated hemoglobin, that is the HbA1c, is going to be a more useful useful parameter to look at. You want to do an HIV test. And then there's this issue about procalcitonin. So when you talk about markers of infection, procalcitonin has got very call it a dignified position as far as markers for bacterial infections are concerned. So procalcitonin is a precursor to the hormone calcitonin. Remember, calcitonin is a hormone which plays a role in calcium homeostasis. So procalcitonin, that's the pro-hormone of the same, of the calcitonin. And it actually gets elevated when a patient has got bacterial infection. It's not elevated in viral infections, but specifically for bacterial infections, it gets elevated. So you realize that in well-resourced settings, clinicians actually use procalcitonin as a marker to say, okay, how severe is infection? How is the antibiotic response? Because when now you see the procalcitonin levels going down, in most cases, that's going to mean that the patient is responding well to the antibiotics. And at that point in time, you might even have to decide to maybe do a de-escalation of the antibiotic therapy. So procalcitonin is a very important marker for bacterial infection, which can only hope that we might be able to do that in our own setting here, but it's very, very, very important. Something also goes for blood gas analysis, specifically the lactate component of it. So these are going to be tests which are going to help us to be able to monitor and manage our patients better. And then microscopic culture and sensitivity tests, they're very, very important because they're going to guide the antibiotic therapy which we're going to give our patients. Because remember, in this day and age, we have a lot of multi-drug resistant pathogens which are out there. So you don't want to be pumping your patient with antibiotics which are not doing them any good. So the MCS results will help us to narrow down to an antibiotic to which the pathogen is sensitive. Okay. Then also in terms of the imaging, when I do the dental panoramic radiograph, chest radiographs discussed. So the dental panoramic radiograph is going to help us to try and identify the source of infection, especially for patients with audiogenic etiology. The chest radiograph and CT scan is going to be determined by the clinical findings that you get when you examine the patient. You're not going to do that for everyone, but for the CT scan, especially for very severe cases, and also for infections which involve the neck, the cervical facial spaces. So you might want to do a CT scan for those patients. Okay, so how do we manage low-dose angina? We want to do surgical source control. So for every patient who's going to come with an abscess or the cellulitis or low-dose angina, we want to do incision drainage. And then also want to extract any offending teeth if they are there in the mouth. Okay, and then you want to do intravenous empirical broad spectrum antibiotics. So before you get the microscopy culture sensitivity test results, you have to give the patient empirical antibiotic regimen. So the one which is normally used around here, we have ceftriaxone and metronidazole. Those are the dosages which are shown on the screen. And then also you can do augmentin monotherapy. That would be a high dose augmentin, but I know that some other clinicians are not comfortable with just giving augmentin alone, but really augmentin at high doses has been shown to be effective for both aerobes and anaerobes. So some people are going to give augmentin with metronidazole, but also actually high dose augmentin might actually just be enough for the patient, but more importantly, you want to be able to monitor their response to the antibiotics. Okay, but the moment you get the MCS results, now you want to narrow down the antibiotic regimen to that antibiotic to which the pathogen is sensitive. And remember that most of the patients are going to come with dysphagia, with dehydration. You want to give them intravenous fluids. That would be our crystalloids, like the normal saline, the venous lactate. For adults, generally around 3 liters per 24 hours, but patient monitoring is very key. And then also you have to do management for specific complications. So we just want to take a look at management for airway complications, the respiratory complications. There's an issue about steroid use where we have compromised airway, and it's really controversial. Apparently, there are not many studies which document outcomes from steroid use and what have you. But because steroids are anti-inflammatory, when you get a patient with a compromised airway, and remember we're talking about the edema, really even from patients that have been part of their management, we've seen that steroids can actually work wonders. We've had a few patients whom we've given like maybe 8 milligrams dexamethasone IV, maybe just even a start dose, and within 12 hours, the swelling has gone down, and realize that they no longer need theater anymore. So steroids really can be very useful, but you're not going to give them like for 4 or 5 days. You just want to give them during that time when you can see that there's airway compromise. Usually we don't usually go before we don't go like beyond 2 days. So steroids can be very, very useful. And then also for those in very serious airway compromise, you want to do endotracheal intubation, you might have to do a tracheostomy. And where we have pleural effusions, the epihemathoracis, you might want to do an underwater seal chest tube drain, as you can see in this picture. Then also there might be need for chest physiotherapy. So when you take a look at the intubation, the tracheostomy, the chest tube drain, and chest physiotherapy, you actually see the importance of managing these patients sometimes as a multidisciplinary team. So you see your competencies or what you can manage to do on your own, and what you may need to call other specialties or other cadres to come in and input into the management of the patient. Then also we spoke about sepsis and septic shock. So we just want to see how we can manage septic shock. So the surviving sepsis guidelines are going to be very, very important in managing the patient with septic shock. And so just a summary of what it entails. We want to do aggressive intravenous antibiotics. We've already spoken about the empirical ones and the narrow spectrum when you do the MCS. Okay, and then with the IV fluid resuscitation, so we're taking a look at least 30 mL per kg in 3 hours. That's usually of venous lactate, maybe saline as well. Okay, so now when you do the IV fluid resuscitation, it means that the patient is going to be monitored. We have to check the patient's blood pressure, especially that. So when the blood pressure is not going up, that's a poor or a non-responder. And that non-responder, remember we say that this is a medical emergency. You have to do an ICU consult. So most intensivists actually, ideally, all intensivists are supposed to be very capable of managing these septic shock cases. When someone is not responding to the fluid challenge, then they might have to be given vasopressor agents and positive inotropic agents so that you increase the contractility of the heart so that you can try to improve the tissue perfusion. So that will be septic shock management. We just want to take a brief look at cervicofascial necrotizing fasciitis. So this condition was described by Wilson in 1952, and here we have rapidly progressive bacterial infection, which is characterized by edema and necrosis of the subcutaneous tissues. So there are 4 types of cervicofascial necrotizing fasciitis, but we're just going to limit ourselves to the discussion of the type 1 and the type 2. Just a simple distinction. Type 1 is going to be polymicrobial, and type 2 is going to be monomicrobial. And the monomicrobial ones, usually the pathogen, which is usually implicated at the group A beta hemolytic streptococci, mainly step pyogens. And then for the polymicrobial ones, we can have the strep also combined with the staph aureus. Sometimes also get E. coli in the same. Yeah, so that would be polymicrobial type 1. So the inoculation can be through external trauma or even the respiratory. So for the external trauma, the actinomyces, remember we spoke about the war zones or people who work in the field. When you get trauma while working in the fields, you can even then get infection from actinomyces. So it can be either external or direct spread from odonogenic infections. So in this picture, it's just showing us just cross-section of the skin, okay, with muscle at the bottom there. But anyway, remember the epidermis is avascular, so we don't have blood vessels within the epidermis. How does the epidermis survive? It survives from the fusion of oxygen and nutrients from the underlying dermis where we have the blood vessels. Okay, so let's just remember this this picture. So as we discuss the pathogenesis of cervicofascial necrotizing infection. So when we have bacterial inoculation into the subcutaneous tissues, remember we have the bacteria releasing endotoxins, exotoxins, okay? We have the lysosomal enzymes. These lysosomal enzymes, the enzymes from the patient's host cells. When we have cell lysis from the infection, these lysosomes are opened up or they break up, and all those enzymes which are contained within are released into the tissues. So now these enzymes are the ones which are going to digest through the subcutaneous tissue. So remember also the subcutaneous tissue with a lot of adipose tissue, fat. And fat, it offers very little resistance to the spread of infection. So these enzymes, we have hemolysins, we have DNases, proteases, and collagenases. And again, the inflammatory cytokines which are released, for example, tumor necrosis factor alpha, that one, and also because of the trauma to the blood vessels, we're going to get exposed collagen fibers. When we have the inflammatory cytokines, the exposed collagen, that's a very good recipe for thrombosis. So we're going to get platelet plugs being formed, and those thrombi, they end up clogging off subcutaneous blood vessels. So now when you clog off those blood vessels, you're going to get ischemia and further tissue necrosis, especially over the overlying epidermis and the other tissues. So this is like, in summary, just how the necrotizing fasciitis actually spreads, how the disease process is like. So the clinical features that we get for the skin can be divided into 3 stages. The first stage of erythema, tenderness, beyond the erythema with swelling and hot skin. And in the second stage, you're going to get formation of skin blur with blister and skin fluctuation. Stage 3, we have crepitus, we actually have frank skin necrosis, we have gangrene. Yes, so those would be the 3 stages of skin involvement. Then we have dishwater pus. So this dishwater pus, it's not like the creamish white pus that we tend to get used to in a frank abscess, but it just has a distinctive color to it, which is a bit difficult to understand, just a mix of things, not the usual creamish white type of pus. And usually it's very, very foul smelling. So we are going to get more order in this patients. So this picture just showing us as a patients with necrotizing fasciitis, how they might present. So the complications can be related to infection or to skin loss. Someone would just confirm for me if you can hear me. Okay, thank you.
Yes, Doc.
It's okay, thank you for the confirmation. Okay, so for the cervicofascial necrotizing fasciitis, the complications related to infection include the sepsis, erosion of blood vessels. You can have disseminated intravascular coagulation, that's DIC, you can even get death. Okay, and the ones which are related to the skin loss can be impaired thermoregulation, body fluid shifts, spore infection, and you can get contractures. Like now in the region of the neck, when we manage those patients, we need to be very careful to try and avoid the development of contractures. So you might realize that in those cases, actually, you might even need to do a lot of physiotherapy so that the patient won't end up with limited neck movement because of those contractures. So the investigations for necrotizing fasciitis and the ones for Lod's angina, they're essentially the same. The only thing which we can maybe highlight here now is the issue about the tissue biopsy. Tissue biopsies are rarely used, maybe just depends on the setting, but tissue biopsy, that's going to be the gold standard for the diagnosis of necrotizing fasciitis, but we rarely do them. That's only going to be the only other thing which is different from Lod's angina investigations. So the management will be under intravenous antibiotics. In these patients, we do serial debridement. So this is a patient that you're going to take the theater today, and then maybe after a few more days, we realize that we have to take them to theater again. So we do serial debridement with these patients, and ultimately, when the infection is cleared, there might be need for skin grafting. So if they have any teeth, they need to come out. You do the IV fluids, and for necrotizing fasciitis patients, nutritional support is very key. They need a high protein diet, and also they will need the physiotherapy, like we've already alluded to. I just want us to take a brief look at this study, which was which we did at the Kenyatta National Hospital. The aim of the study was just to describe the treatment outcomes for patients who presented with this life-threatening cervicofascial infections. So this way, inpatients, okay. So 202 inpatients, the records of them we used for this study. The overall male-to-female ratio was 2:1. So for some reason, this infection seems to be more common in males. So some attribute this to the poor healthcare seeking behavior among males, but I guess it can be debatable. But that's in almost every study which is done on these infections. There's always a higher a proportion of male patients. Okay. And the amount of age brackets were the first, the third, and the fourth decades. And notably, only 14.4% of people in that setting. I think the setting is not so different from ours, or almost like the same, but we haven't really done, okay, since I've been back, we haven't really done an audit in our own system to see how we fare compared to other countries in the region. But the issue of delayed presentation is quite rife among our communities. So only 40.4% of patients presented to the oral and maxillofacial surgery department within 3 days of the swelling, some straight from home, some maybe the delayed referrals from other centers. But we also realized that for all these patients, facial swelling and pain were actually universal. And in this study sample, 69.1% of patients had odontogenic infection, which was documented. So it probably could have been more patients with odontogenic infection, but the ones which were documented were 69.1%. And then about 27% of the patients actually no source of infection could be identified. So this is a bit common, like I already said, in the pediatric age group. So the distribution of the diagnosis, we can see ludus angina was the commonest diagnosis for the admission of these patients, and then also submandibular abscess. Then we have the necrotizing fasciitis, and remember ludus angina complicating to necrotizing fasciitis. So this contributed 9.4%. Okay, and by gender, the key thing to notice that of those 202 patients, there was an approximately 5:1 male gender predilection for necrotizing fasciitis. So I think this can be like a question or investigation for another day, why the outcomes, okay, first of all, the incidence or the prevalence, and then also the outcome, it tends to be worse in male patients compared to women. Okay, and the risk factors, the one which was quite common was anemia. So most of the patients were actually anemic, and I think but one thing which is actually important for us to be able to do, I don't know how people are managing patients, how we're checking our clinical history, but it's always important to ask the patient's HIV status. So in this setting, for some reason, a number of the patients, more than 50% actually, they didn't know their HIV status. But it's very important for us to know, because you can manage the ludus angina, you can manage the necrotizing fasciitis. You let the patient go and they've got undiagnosed HIV infection. So you want to manage the patient holistically. So looking out for these risk factors, these comorbidities is very, very important. And then for the antibiotic regimens, which we instituted, there were more than 10. I think when you take a look at this, it just points to an issue about a lack of protocol. Sometimes the protocols will be there, but people don't follow them. But here, I think we still maybe need to take a look at this, the issue of the antibiotic protocols, but metronidazole and ceftriaxone, and then metronidazole and augmentin, those with the commonly used antibiotics together with augmentin monotherapy. But there were some other antibiotic therapies which were just given haphazardly without really following protocols. And this gives us problems, this we shall see a little bit later on. So in terms of the hospital stay, so when you get this infection, especially necrotizing fasciitis, you can stay in the hospital for a very long time. So the range of the hospital stay, it was from 1 to 172 days. The overall average for the 22 patients was 14 days. But we realized that for patients with necrotizing fasciitis, they actually stayed for 38 days, whereas for the other patients without necrotizing fasciitis, it was actually 10 days. So the 14 days was when we combined everybody, but necrotizing fasciitis against other infections, it was 38 days versus 10. So the NF patient is going to stay longer. And then also diabetic survivors, also the diabetics who did not demise, they spent 2.6 times more hospital days than the ones who were not diabetic. So we also need to work hand in hand with the physicians when we're managing patients with comorbidities like diabetes. But we already know that they're predisposed, but whatever we can do to try and improve the outcome will be good. The complications which were encountered with skin necrosis, upper airway obstruction, septic shock, pleural effusion, and then 15 patients died in this study sample. That was 7.4% of the patients. So this this is quite high when you compare to developed nations. And I think the main issue was about patient monitoring and then also even identification of those fatal complications. I think we won't stay long on this mortality profile, but what I just wanted to pick up on this, for this 15 patients who passed on, at least, okay, every one of them had at least some comorbidity of some sort, including diabetes mellitus, some had hypertension, and then there was one lady who was pregnant. So the question is asked, how do you manage dental infections in pregnant women? I know most of the time we say want to do any procedures during the second trimester because it's safe. So yes, that's a good guideline. But remember also, when you see a patient and you can clearly tell that actually sometimes it's a bit difficult to try and think, okay, which one is going to complicate. It's difficult to really tell, to predict. So maybe I think we just need to try and see when you need to do maybe an extraction, when you need to do a filling in a pregnant woman. We might want to stick to the second trimester, but if you have to do something in the third trimester, it's better if you're going to save the patient's life, because the moment they get these infections, really, they're at a very high risk of becoming immortality. So maybe we want to keep that in mind in terms of management of pregnant women. And there were some few rare complications. The erosion of the carotid artery, it was actually documented. Okay, and then also notably in terms of the deaths, the time of death, so like the majority of the patients actually died within a week of arrival, and 6 of them actually within the first 3 days. So this just points to an issue of late presentation. So when we do our oral health campaigns, maybe just trying to encourage people to present early, because when you come late to the patient, to the hospital, there's not much which the healthcare worker will be able to do to salvage life. And then also the last point here, like 10, that's like 2/3 of the patients who passed on, they did not receive any corticosteroids. And also the same number didn't receive any surgical management. So because this was not a random clinical trial, we can't really come to a lot of conclusions, but you try to think, if this patient has gotten corticosteroids, if they've had surgery, would they have survived? Possibly. So maybe those are some of the questions that we might want to just take a look at. So, okay, so one of the main challenges that we have in managing these patients is the issue of antibiotic resistance. So we realize that the rate at which new antibiotics are being discovered or being produced is very low compared to the rate at which antibiotic resistance is being acquired. So this just comes back to us also as clinicians in terms of our antibiotic stewardship. In which case, what are the indications for antibiotic therapy? What is the antibiotic, like, okay, the drug class, the dose, the duration? So that's very, very important for us. And I think one of the issues that we've been encountering is people maybe just prescribing antibiotics for somebody with a common cold. And then the question is, why are you giving an antibiotic for a bacterial, for a viral infection? So those questions. So as we close up now, so I think there are a few action points that we could adopt in our different capacities. Some can be advocates, some may be able to provide resources one way or another. But it's very important, like sometimes we get patients coming from very far away towns, and maybe they're not on any antibiotic. There's not been any prior communication about the patient arriving. So it might be important to do a pre-referral alert. When you get a patient with reduced angina in the remote areas, and you want to transfer them maybe to Harare here, just call the doctor who will be there, tell them about the patient, give them a summary, let them prepare for the arrival of the patient. That might help us in terms of giving the patient timeous intervention. Okay, and then you want to start treatment before referral. Don't send the patient to a higher center of care without giving them any antibiotics. Start treatment where you are. Then the treatment can be continued when they get to the referral center. And then also we need to be intentional about investigating for the red flags that we've already alluded to. So this is very, very important. We need to look out for airway compress. We need to look out for sepsis and septic shock, document and do something about it. And then the other issue, which might be out of This might not do much about it, it's only to advocate, but we need to be able to improve on laboratory support for biomarker monitoring. That's very, very important in our systems. We may need to advocate for that. It's going to go a very, very, very long way in terms of patient management, because sometimes if a patient is gravely ill, you can't get the test that you want to do. So this might be very, very helpful. Then also multidisciplinary patient management. Don't shy away from consulting other specialties, other cadres, so that they can give the input in the management of the patient. And then also in our different centers, we also need to make sure that we have case management algorithms to say when a patient comes, what's the case definition for submandibular abscess? What's the case definition for this angina? What's the protocol? What's the patient flow? For us to be able to get them to the point where they're going to get the care which they need. So these are some of the action points which I thought of, but I know all of us we have some input that we can bring forward. So the issue now is we don't really have current data on our patients at the central hospitals, but this year alone, I think we've had a few days. You know, when someone comes, a ladies and gentlemen patient comes to the clinic, people like Shiba, they say, oh, someone has come. So we already know we're having issues. We know that we have issues which need to be resolved. So I think everybody should be able to give the input so that we can improve on the outcomes for the management of these patients. Thank you.
Thank you very much, Doc, for the very comprehensive presentation. At this point in time, we'll take questions or comments, if there are any. I'm not seeing any hand or any questions in the chat box. I'm just curious, Doc. You gave a time frame of 1 to 172 days admission. Would you have any idea what was happening for the patient who was in there for about 172 days?
Okay, so for these patients now, we have such a very, very long hospital stay. Almost always, that's going to be a necrotizing fasciitis patient. So with necrotizing fasciitis, sometimes it can be very, very, it can be quite debilitating, like I'm saying, like from the neck to the lower limbs, maybe the upper part, like the pubic region thereabout. So now the number of times that you're taking the patient for the serial debridements, and the patient has got a low BMI, sometimes they get urosepsis, sometimes they get into the ICU, and then they have to come out. You want to clear the infection. You want to do a skin graft and asking yourself, where are we going to get the skin from? So those are some of the issues which prolong the hospital stay of the patient. It can be really, really hectic. But also, like I'm saying, the metabolic status of the patient, the nutritional status sometimes can just be so deranged to the point whereby you're just trying to manage the patient, just make sure that they survive the next day, but you know that it's really an uphill task managing that. So necrotizing fasciitis, with comorbidities, low BMI, that can be very debilitating. Yeah.
Thank you. There's a question in the chat box. It says, thank you for the presentation. Are there any socioeconomic patterns you've noted in your experience with patients presenting with these infections?
Okay, so the socioeconomic patterns really, I would say it's anecdotal. I haven't really looked to say, okay, what was the income status of the patients who live longer and all that. But I think it's generally agreed on that many people who are well up can manage to go to the dentist or the hospital. Like any other time, they've got good medical insurance. So most of the patients that we end up getting in the public hospitals with such infections, they're usually people who have got a low income. And maybe Doc, you can try and find out why males, but in terms of the income, definitely low income patients coming from sometimes from the rural areas, from slums,